Now, next speaker is Dr. Sanjay Kumar. He is professor and head of department of CTBS department, IMSBHU. He will talk on surgery in valvular heart disease, the guideline recommendations. So, sir, welcome.
Thank you so much. Are you able to hear me?
Yes, sir.
Yes, we can hear you.
Okay. I'm sharing my screen. You able to see that as well?
Yeah.
Yes.
Okay. Just give me one sec. Okay. Good evening, chairpersons, and I really I want to congratulate and thank Dr. Alok for organizing this scientific program, and this is really wonderful, and it is ongoing for last several years. And the topic that has been given to me is surgery in valvular heart disease. What do the guidelines say? And our special focus will be on TAVR for the patient who have indication for undergoing aortic valve operation surgery. So I'm just going to touch base with the two of the guidelines which has been recently published. These are the latest guidelines. In 2020 December, this AHA guideline has been published about from the American College of Cardiology, American Heart Association, and there is another one which is European one that came up in 2021, the beginning. So mostly my focus will be on the AHA guideline, because I did look into the literature for if there's any Indian guideline that is available for managing the patient with the valvular heart disease, but apparently there is no comprehensive guideline like what is the American or European one. So I'll focus on the American Heart Association guideline. So I will go in that order of various valvular pathologies because it's limited time, and we'll try to focus on the surgical indication for these patients, especially specific pathology, which is like mitral stenosis, mitral regurgitation, tricuspid valve regurgitation, aortic stenosis, and aortic regurgitation. Pulmonary valve pathology, the majority of them are congenital pathology. It is not in the domain of this talk today. So we will start with the mitral stenosis. Majority of the pathology what we come across in our clinical practice and all over the world, it is the rheumatic mitral stenosis. So if you really see the severe mitral stenosis, so it is for the sake of clarity, it is broadly classified into based on the echographic echocardiology finding. It could be severe MS, which is where the valve orifice area is less than 1.5, or progressive mitral stenosis, where the valve area is more than 1.5 square centimeter, but the patient is symptomatic. So now let's talk about the severe MS. So if the patient is symptomatic, which is the stage D disease, the valves are pliable, there is no LA clot, and if there is, if you really look at the degree of MR is less than 2, if all these criteria are fulfilled, then the patient goes for percutaneous mitral valve commissurotomy at a comprehensive valve center. If it is not, then in that case, if any of those, like if there's LA clot, if there's valves are not pliable, in that case, and the symptoms are severe, with the patient in NYHA 3 or 4 class, then in that case it becomes a surgical candidate. So when you talk about surgical candidate, what do we do that? So if it is surgical candidate, if it is fit to undergo surgery, then in that case subject them for mitral valve surgery. And depending on the age, we decide about whether it's going to be bioprosthesis or mechanical valve. And if it is not a suitable candidate for surgery, then in that case again you consider the percutaneous mitral valve commissurotomy. but the indication there, it is 2B, unlike the first one, which is the class 1 indication. If the patient is severe mitral stenosis on the echocardiographic criteria, but the patient is asymptomatic, which is called stage C. The valves are pliable, there is no clot, there is degree of MR is less than 2, then in that case, and if you find that the pulmonary artery systolic pressure is more than 50, then in that case you subject the patient for percutaneous mitral commissurotomy, again percutaneous intervention at comprehensive center. If the patient has new onset atrial fibrillation as well, then in that case still the percutaneous intervention is recommended, but with the class 2B indication. Now we are talking about the another group, which is the progressive mitral stenosis, where the valve orifice area is more than 1.5. If the patient has dyspnea on exertion, you subject them for stress test. If you have and again, if the patient has a hemodynamically significant mitral stenosis, and valves are pliable, there is no clot, no less than this degree 2 of MR, then again it's a percutaneous intervention. But you across the board, you remember that it always comes if the valves are pliable, there is no LA clot, or if there is no MR. If any of these are present, then it becomes a surgical candidate, and then you consider them for surgery. So all the cases, most of them can be subjected for percutaneous intervention. However, if you have what we normally look at here is the Wilkinson score, that if it is high, then in that case the patient are subjected for surgical replacement or repair of the valve, whichever is feasible. Now, next one we are going to talk about the primary mitral regurgitation. So when there is a primary, there is a secondary as well. The primary is the one where there is a valve is at fault, the valve leaflets are involved, and there is commissure involved, there may be subvalvular apparatus that is involved as well. So that leads to the patient with the mitral regurgitation. If there is a patient has a severe mitral regurgitation, again, here you look into consideration the echocardiography has got a significant role to play. So it's an echocardiographic assessment that gives you, if there is a vena contracta, it is more than 0.7 centimeter, or if the residual regurgitant volume is more than 60, regurgitant fraction is more than 50%, or this regurgitant orifice area that is more than 0.4 square centimeter, then in that case, based on these criteria, if the patient has a symptom due to MR, if the patient is symptomatic, then in that case, the stage D, and regardless of the LV function, whether the patient, because majority of these patients, if they start dropping the ejection fraction, in that case, they develop the LV dysfunction, because in normal LV with a severe MR, we expect the ejection fraction to be in the means at least 65 and above. If it starts coming down, then in that case there is a systolic dysfunction, LV dysfunction. So if there is regardless of the LV function, when you subject this patient for the mitral valve surgery, that is class 1 indication. And if there is a high prohibitive risk of, or if it is and the anatomy appears favorable for transcatheter approach, and life expectancy is more than one year, then in that case, transcatheter, because now you know that the transcatheter treatment for the mitral valve regurgitation, which is the S-to-S repair, in order to get the effective coaptation of those leaflets, are coming more and more into the picture, and that forms in fact the class 2A indication. So now we are talking about those patients, again, mitral valve surgery. If there is a degenerative mitral valve disease, rheumatic mitral valve disease, again, because there the whole thing changes. But if there is a degenerative mitral valve disease, which is more common in the Western country, unlike our scenario, where more predominantly it is the rheumatic mitral valve disease. So if it is degenerative mitral valve disease, and if it appears that they can be successfully repaired, then in that case we use the various, depending on the what kind of pathology it is. They require a very detailed transesophageal echo assessment. We look at the leaflet, if there is any cleft, or if there is any prolapse, or if there is any component of posterior or anterior mitral leaflet that needs to be addressed, or if there is any chordae rupture or lengthening of chordae, whatever is responsible, that needs to be addressed, and then you can successfully repair it either with various surgical technique are available, which and even artificial chordae may be used in order to get a successful repair. But every repair is always complete with the annuloplasty ring. So you must have an annuloplasty ring to complete this reparative procedure of mitral valve repair, regurgitated mitral valve. If it is rheumatic mitral valve, if it is again, if it is because there are situations where if there is not much of calcium, the annulus is not calcified. If you have because if you can decalcify the leaflets and in order to maintain that coaptation, or if there is a commissural some stitches that may be needed in order to get those valve coapting well, then in that case mitral valve repair can be considered at comprehensive valve center. When we are talking about comprehensive valve center, this is a situation where that's like a heart team approach. So you have a surgeon and the cardiologist who have done the detailed assessment of the using the echocardiography. They all form the team and they make a best decision for this kind of patients. Now let's look at the other situation where the patient does not the patient is asymptomatic and there is a normal LV systolic function. Then in that case, where the ejection fraction is more than 60, in systolic dimension is less than 40, then in that case, and if you find that the surgical mortality, which is like a very low surgical risk of these patients, and that there is a more than 95% likelihood of successful and durable repair without residual MR, then in that case you again consider the mitral valve repair at a CVC. If it is not, or if there is a progressive increase in LV size on serial echo and decrease in the left ventricular ejection fraction at last 3 studies, then in that case these patients are subjected for surgical mitral valve repair or replacement, whichever is deemed necessary for this patient based on the echocardiographic assessment. Now, secondary mitral regurgitation. Here is predominantly the leaflets and are not at fault, but there is other because the LV is dilated. There is an annular dilatation, and these patients they are actually or there is a symmetrical or asymmetrical dilatation of the this annulus, which can lead to the significant MR. Then these are called secondary mitral regurgitation. Again, first, GDMT supervised by heart failure specialist guideline-directed medical therapy is always the mainstay of treatment. Subsequently, CVMR, if it is stays D, that means it is regurgitant volume is more than 60. Regurgitant fraction is more than 50%. ERO is 0.40. In that case, you look at the ejection fraction. If ejection fraction is more than 50, and if it is severe and persistent symptom despite being on optimum GDMT, and the patient has been on atrial fibrillation treatment, then in that case the patient needs to be subjected for mitral valve surgery, and that forms the class 2B indication. So this now, if it is ejection fraction is more than 50, then in that case, if the patient has persistent symptom on optimum GDMT, mitral valvular anatomy appears favorable. Left ventricular systolic dimension is less than 70, and the peak pulmonary artery systolic pressure is less than 70. Then in that case, transcatheter percutaneous technique, which is using the S-to-S mitral valve coaptive procedures, they are the ones which are used, and that forms the 2A indication. If no, and the patient is severely symptomatic, then in that case the patient needs to be subjected for mitral valve surgery, which forms the class 2B indication. If the patient has severe MR and the patient also has coronary occlusive disease, coronary artery occlusive disease, and patient is undergoing CABG for that, then in that case, it is you must do the procedure as a concomitant procedure, and mitral valve surgery is done, and that forms the class 2A indication. Here, majority of the time you can get away without replacing the valve. However, if the leaflet appears tethered or the annulus is too much dilated, in that case you may have to consider mitral valve replacement, preserving all the both anterior and posterior mitral leaflet in these patients. Tricuspid regurgitation, we are talking about these are the majority of these are, you must understand that whenever we talk about tricuspid regurgitation, most of them are secondary TR. Only less than 10% of them are primary TR. So secondary TR, if it is severe TR, stage C and D, and if you have, then again they are in different categories. If at the time of left heart surgery, like if the patient has mitral stenosis or any valvular pathology on the left side, and the patient is being subjected for valve procedure on the left side, then if there is a severe TR, then in that case the patient must this reparative procedure. Most of the time you have to do the annuloplasty. Valve replacement is very uncommon. And again, when you talk about the annuloplasty, there used to be a suture annuloplasty, which is like a DISEASE technique or case method. That those have been now fallen out of favor, and this majority of them they need bands or flexible or a rigid type of annuloplasty ring. Rigid rings, in fact, it has been found that flexible rings do as good as the rigid rings. Rigid rings or 3D rings, they are the ones which are actually they're costly affair, but and it doesn't seem to be any superior compared to the flexible band. So majority of the time we do the annuloplasty, tricuspid valve annuloplasty using the flexible band. So we are talking about at the time of left surgery, if you have any severe TR, you must subject this patient for this thing. If it is left untreated and the patient comes back with a TR later on, which always they do, majority of them,
Sir,
then
we have shortage of time.
Yeah, I'm just going to move to the aortic next. So in that case, the patient will we need, this is a class 1 indication. If it is any other reason, then you must see that if there is a primary TR or severe one, again class 2 indication. If the patient has poorly responsive to the GDMT, then in that case the patient needs to be subjected for tricuspid valve. Whenever we talk about surgery, it is the annuloplasty we are talking about. If the patient had prior, if the patient, in that case the patient has a recurrence, then in that case again the surgery is indicated. Asymptomatic patient, if it is stage C, but it is progressive in nature with the severe progressive dilatation of the RV and systolic dysfunction, it forms a 2B indication for performing surgery. If it is a progressive TR at the time of left heart valve surgery, annular dilatation, this is the criteria majority of the time we look at. Because even if the patient is having a moderate TR on volume wise, but if you really see the annulus is dilated, and then in that case, the patient must be subjected for annuloplasty, and this forms the class 2A indication for tricuspid valve surgery. Now, aortic valve, this is a procedure we are talking about in patient with the aortic stenosis. The patient who has asymptomatic, patient who is symptomatic, if they have a severe AS, which is assessed with the Vmax of more than 4 or pressure gradient of more than 40, then in that case AVR, surgical AVR or TAVI, both of them can be considered. If the patient has again Vmax of less than 4 and valve orifice area is 1, then in that case if the ejection fraction is less than 50, then in that case the severe, you must subject this patient for dobutamine stress echo, and if that generates a good flow rate, then in that case you consider the patient for surgical or TAVI. And if it does not, then in that case the patient has if the orifice and systolic volume index is less than 35, then certainly the patient has AS as the most likely cause. Then in that case the patient should be subjected for a high risk surgical AVR or TAVI. and this forms the class 1 indication. Now we are talking about asymptomatic ones. So if they are in stage C, which is the Vmax is more than 4 and ejection fraction is less than 50, again surgical AVR. If they are getting subjected for any other cardiac surgery, surgical AVR, if the patient has exercise tolerance, ETT with decreased blood pressure or decreased exercise capacity, in that case surgical AVR is considered with a class 2A indication. If Bmax is 4 or if the BNP is raised 3 times, if the patient has a rapid disease progression and the patient low surgical risk, surgical AVR. And now we are talking about the patient who are decreased ejection fraction to less than 60% in 3 consecutive echo, then in that case surgical AVR with 2B indication.
Sir,
Now stage B disease, which is the 3.9 Bmax. In that case, if they are getting subjected for any other cardiac surgery, in our situation, it is important because these patients, they come for only one operation. So you must make sure that you subject them full operation. So in that case, for our scenario, it will not be 2B. It may even become class 1 indication.
sir, kindly summarize, sir.
It's a little different.
We are getting delayed.
Okay, so now this is the patient where we're talking about TAVI and versus surgical AVR. So the patient, if you really see the patient indication for AVR, means these patients are already a case for who needs valve replacement. Then in that case, you do the risk assessment. If the estimated risk not high or prohibitive, then in that case you also look at what are the vitamin K and
Kindly summarize, sir. We are getting delay, sir. It's still
yeah, so actually this is the problem because this flow chart, if it is going through. Okay, so what we are going to talk about is surgical AVR and TAVI. Okay, surgical AVR is indicated for those patients who are less than 65 years of age, low surgical risk. If the patient is 65 to 80 years, surgical AVR again or TAVI may be considered in these patients. If the patients, you always look at the life expectancy of these patients as well. If they have any other, if the patient is elderly patient, if they are very frail, they are not a surgical candidate based on these category, then in that case the patient should be a candidate for TAVI. Aortic regurgitation, AVR is severe, all the patients who have a severe aortic regurgitation, symptomatic AVR. If they're asymptomatic, then in that case, looking into these criteria, you subject them for AVR. That forms the class 1 indication. 2A, if the ejection fraction is more than 55, but LV in systolic dimension is more than 50, and LV in systolic dimension is more than 25 millimeter square meter, then AVR with class 2A indication. Progressive decrease in left ventricular ejection fraction, low surgical risk is still AVR with 2B indication. Moderate AR, other cardiac surgery, again, as I said, that these patients we come across very commonly if they are having mitral valve procedure, but they do have a moderate AR, then in that case we subject them for DVR. So that forms a class 2A indication. I'll skip these slides because they are the ones, bicuspid aortic valve, there are some, because they need a regular imaging in order to assess the progression of the disease, and also they also need assessment in order to replace the aortic valve as well as the aorta sometimes. So prosthetic valve, and again like now if you just one slide, I'll finish this one, because if the patient how do we decide about whether we're going to use the mechanical valve or processes? So you look at the vitamin K antagonist, if they are okay for that, then in that case aortic valve replacement patients is, we look at if it is less than 50 mechanical AVR, 50 to 65 mechanical or bioprosthesis, more than 65 it is the bioprosthesis. So that is the cutoff. It's a gray area which is like around 60 years we start deciding. But for Indian scenario, in fact we can consider the life expectancy. Yes, so that's why it has to be. Same thing applies for the mitral valve replacement. And if there is a vitamin K antagonist or means contraindicated, then in that case the patient should have bioprosthetic valve. So with this, I would conclude my talk actually. Okay. So if you have any questions, so you